A healthy market facilitates choice and competition. It means that people at the end of the day will be able to go get the healthcare that they need, when they need it, where they need it, at a price that they can afford. The problem with less competition in markets today means that consumers have fewer choices and they're paying more for healthcare. Think about a hospital system that is just one in an area. If you had 2, 3, 4 that were competing for the business of treating patients, it would force hospitals to compete not just on price, but on quality, and make sure that at the end of the day, costs were lower. And we know that that would benefit patients and other people that are paying for healthcare. We can make markets more competitive by improving transparency. This is not something that health insurance providers alone can solve. We need to work with government partners. We need to work with other participants in the healthcare system to make sure that we're getting new choices to come in to reduce prices, to make sure that healthcare is more affordable, accessible, higher quality, and of course, lower cost for consumers.
Hello, and welcome to AHIP's annual State of the Industry event, where we offer our projections and outlook on the most essential healthcare trends and milestones to watch in 2023. I'm Christine Grove, Senior Vice President of Communications and Public Affairs. We begin our event with insights from AHIP President and CEO Matt Eyles. Matt will give his perspective on where things stand in the federal and state landscape, particularly as it applies to healthcare. He will then examine challenges and opportunities to improve America's healthcare system. Matt will then be joined by a panel of AHIP experts to explore in further detail key healthcare issues, policies, and solutions to improve healthcare for more Americans. And we look forward to introducing them to you shortly. There will be a moderated Q&A session where your questions can be posted to Matt and to the panel. Please submit your questions to the moderator through the chat function, and we'll get to them as time allows. Now on with the show. Matt has more than 2 decades of healthcare experience in the private sector and in government, and that gives him a unique perspective into what's shaping the healthcare industry, considering legislative, regulatory, and innovation trends. And today, he's bringing those insights to you. Matt, over to you.
Thank all of you for attending our State of the Industry event. I really appreciate you taking the time today, and I see that we have participants from inside the Beltway and across the states, representing members of Congress, regulatory leaders, state leaders, members of the press, business and industry, and other organizations focused on healthcare. And together, you represent essential voices in healthcare, policy, innovation, and I'm looking forward to your questions. So why don't we go ahead and dive right in? And before we can talk about the state of the industry, I think it's important to just reflect for a moment on how we're starting off 2023 as a nation. And early Saturday morning, I think we were all watching closely. House members of the new Congress were sworn in with a Republican majority in the House and a Democratic majority in the Senate. Of course, that means divided government. And with divided government at the federal level, we know a lot of Americans are concerned that the next 2 years in Washington may be dominated by gridlock, with very little getting accomplished. Now, some might view that positively, others not so much. But against that backdrop, I'm generally optimistic that there are some key areas of agreement and common ground, and several of them are in healthcare. So why don't we maybe start with some of the challenges and what individuals and families are experiencing. And I think across America, inflation, rising prices are squeezing household budgets. I think we're all very well aware of that. Consumers, businesses, and elected officials, I think more than anything, are focused on affordability. And in healthcare, we know that that is the top concern. It's nowhere more evident than really in our healthcare system. And over the past 3 years or so, our healthcare system has been tested in extraordinary ways, ways really that no one could have predicted. But in many ways, health insurance providers, I think, met the challenges of the historic COVID-19 pandemic, which we're still working through. And health insurance providers, came together early on with private market and public sector partners to ensure Americans had access to therapies and vaccines. We embraced telehealth, new technologies, and new flexibilities to ensure patients had access to the care they needed. We worked to ensure that seniors and other vulnerable populations had access to transportation, nutrition, in-home healthcare, and other non-traditional benefits and services that proved to be so valuable to so many Americans. We addressed some unique challenges with respect to access faced by rural America through projects like the Pennsylvania Rural Health Model, in which insurance providers collaborated to provide more consistent funding through global payments to rural hospitals. We worked with healthcare providers to reduce administrative burdens in a way that protected patients and purchasers of healthcare. And we found new ways to overcome workforce shortages, especially in the areas of access to mental health. Today, we are evolving from the COVID-19 pandemic. And while the public health emergency was extended again just earlier today, we know it's not going to last forever. And now, appropriately so, Americans are calling for public and private sector leaders to come together to make healthcare more accessible and affordable for everyone. And we know that this is no small task. But I want to highlight some important trends and developments before we jump in to some of our Q&A. We need to address an unprecedented workforce shortage. The Bureau of Labor Statistics estimates that our healthcare system will need more than 200,000 new registered nurses each year as the need and demand for healthcare access expands, the population continues to age, and retiring nurses rotate out of the workforce. The Association of American Medical Colleges reported that an anticipated shortage of 120,000 physicians overall, including a shortfall of between 14,800 and 49,300 primary care practitioners by 2030. And we also know that healthcare worker burnout is a major concern. Recently saw a Bain survey that found that about 25% of clinicians are thinking about leaving the healthcare field entirely. And along the same lines, an MGMA survey found that more than a third of physicians were considering early retirement. At the same time, though, we're seeing an unprecedented demand for mental health care. At the height of the pandemic, Kaiser Family Foundation study found that 40% of adults reported symptoms of anxiety or depression, compared with only 11% pre-COVID. Now, this percentage has dipped to 33% earlier last year, but it's still much, much higher than pre-pandemic levels. And the mental health care workforce shortage is particularly acute for children and teenagers. And HHS estimates that in 2 years, the nation will have 10,000 fewer mental health professionals than it needs. Substance use disorder is another public health emergency, which affects more than 20 million Americans aged 12 and over. And from April 2020 to April 2021, nearly 92,000 people in the US fatally overdosed on drugs, the single highest reported death toll during a 12-month period. At the same time, we've added new innovative drugs, treatments, and therapies to our healthcare armamentarium, some of which show meaningful clinical promise to help more people live longer, healthier lives. But far too often, we know that they are tremendously expensive, putting them out of reach for patients who need them most and creating enormous strains on our healthcare system. I don't know if you saw, but a recent JAMA analysis reported by Reuters found that the median price of a new drug in 2022 was over $220,000. That's about the same cost as the average annual health insurance premium for 10 families. Now, working together, we need to figure out how to correctly price these treatments and then how to pay for them. At the same time, we continue to expand the application of innovative new tools and technologies, integrating artificial intelligence and using advanced data analytics to provide new opportunities to deliver better service, better care, and better value. But as technology evolves and information becomes more readily available, protecting data privacy becomes even more important. We know that Americans want their data protected. 90% want tech companies held to the same high standard and scrutiny as health insurance providers and other healthcare entities when it comes to protecting their information. Personal health information should be protected no matter who holds the data. And as data becomes more interoperable, entities that collect, use, store, or disclose consumer health information should be required to comply with HIPAA or new HIPAA-like protections. We've also learned a lot of important lessons about health equity and disparities, how they impact millions of Americans, particularly those in historically underinvested or underrepresented communities, and taking action. Our Vaccine Community Connectors program not only put more than 2 million shots in the arms when vaccines were badly needed, but showed us how smart use of data can help us tackle longstanding health challenges, including many chronic conditions that impact some populations more than others. Now, we need to measure, address, and scale-driven, data-driven solutions to ensure that everyone in America has an equal opportunity to thrive and achieve their best health. And last year, AHIP devoted significant energy and resources to align stakeholders in a coordinated fashion to make real progress on demographic data standards. And without such standards, we will perpetuate our fragmentation, our duplication, our inefficiency, and fail to advance our health equity efforts further and faster to the benefit of patients everywhere. Finally, we've made huge strides in ensuring more Americans have the financial security and peace of mind that health insurance offers. Now, we have to work to protect those achievements. During the individual market and open enrollment period that ends next week, nearly 16 million Americans have signed up for ACA marketplace coverage through healthcare.gov and state marketplaces. This is more than a double-digit increase from last year. Seniors and people with disabilities continue to choose Medicare Advantage because it provides better services, better access to care, and better value than original Medicare. For over 2 decades, MA has served as a prime example of the government and private market working together, and we're on the cusp of MA enrollment topping 30 million. We've also seen the important role that Medicaid plays in covering about 1 in 4 Americans, including children, older and lower income adults, people with disabilities, and veterans. However, as America begins the process to ensure Americans with Medicaid are eligible for this coverage, we need to ensure a smooth transition through the redeterminations process. Projections show that up to 16 million people could lose coverage after the expiration of the public health emergency, including nearly 6.7 million children. And with national uninsured rates at historic lows, our industry is committed to working with all stakeholders to make sure that as many Americans as possible remain covered. Now let's turn our attention for a few minutes to challenges and opportunities and solutions before jumping into our dialogue. And as we enter the new year, health insurance providers look forward to leading efforts in partnership with federal and state policymakers to implement real solutions to improve our healthcare system, solutions that deliver high value and return and that have bipartisan support. Let's start with one area, competition, where AHIP has been deeply involved. First, we need to focus on competition and the role it can play in providing Americans with more healthcare choices, greater access, and better quality at lower costs. Last year, AHIP launched our Healthier People Through Healthier Markets initiative. It's our roadmap for improving affordability and access for everyone by improving competition in 10 key areas of our healthcare system. These include supporting patients' choice of telehealth, stopping dominant health systems from using their monopoly power to stifle negotiation and innovation, and stopping drug manufacturers from engaging in patent games. Without robust competition, healthcare providers and systems can charge exorbitant prices that drive up out-of-pocket costs and insurance premiums. Just one example, hospital concentration has been linked to average annual marketplace insurance premiums that are 5% higher than are in less concentrated areas. And over the last decade, private equity acquisitions of hospitals and healthcare companies have risen sharply as some unscrupulous entities seek to generate outsized financial returns for their own benefit. And the soaring interest from some PE firms raises important questions about what does this mean for our nation's healthcare system and for the future of healthcare. Consumers and businesses know and understand the impact this lack of competition has on healthcare. So as we look to 2023, we'll continue to prioritize reforms that remove some of the incentives and opportunities for PE firms and others to exploit patients for profit. Let's turn to mental health. The pandemic continues to demonstrate that mental health is an issue for everyone, whether it's coping with stress and anxiety, managing a mental health condition, or confronting substance use disorders. Americans of all ages need access to mental health support. Mental health is also a major equity issue, especially in historically underinvested or underrepresented communities that are more often forced to contend with social factors such as unstable housing, greater uncertainty in the job market, and systemic racism. Last year, AHIP's board of directors released a detailed statement reinforcing our mental health advocacy priorities, and our members are taking action. Health insurance providers are working to expand our healthcare system's capacity and increase the number of mental health and substance use disorder practitioners in health plan networks. They're developing in-home mental health programs, adding behavioral health beds, training employees on mental health parity, staffing crisis hotlines, and providing virtual resources. We're committed to improving affordability, access, quality, and results for everyone seeking mental health support. Now let's turn to the high cost of treatments and therapies. And there's no question that innovative therapies and treatments, including prescription drugs and others, can save lives or provide breakthrough cures. But we all know that a therapy is useless if no one can afford it. And we've long said that the problem is the price, and we still think that that's very true. Look, we know drug prices are set and controlled by Big Pharma and Big Pharma alone. And if they wanted to lower prices, they could do so now. But another recent report just found that Big Pharma rang in 2023 by continuing its tradition of New Year price increases on existing and old drugs, making healthcare and health insurance more expensive for everyone. Too often, pharmaceutical companies abuse the patent system to prevent more affordable drugs from disrupting their monopolies over the drug marketplace. Generic and biosimilar medications save money, yet Big Pharma takes advantage of a broken system by both increasing prices of brand name drugs and blocking affordable generics and biosimilars. Federal and state policymakers can fix this system by holding Big Pharma accountable. Hospitals and physicians' offices routinely mark up the price of physician-administered drugs too, forcing patients and purchasers to pay more for their life-saving treatments. The same specialty pharmacies that hospitals use can safely distribute these drugs at a lower cost and preventing hospitals and physicians from imposing exorbitant markups and fees on patients. Copay coupons and copay assistance programs also sound helpful, but actually serve one purpose: to pad Big Pharma's bottom line for insured patients. And they drive up premiums and costs for Americans. And you shouldn't need a coupon to afford a life-saving medication. Today, over 22 cents out of every premium dollar is spent on prescription drugs. And finding and implementing solutions to the high prices of drugs is critical, especially when too many Americans are forced to choose between paying bills and getting the life-saving medicines that they need. Let's turn for a moment to data privacy. And every day we know new technologies are emerging that will help consumers access their data. And this is important. Having access to personalized, actionable healthcare information empowers consumers to make more informed decisions. But as the world becomes more digital, protecting consumer health information is essential. Many third-party apps are outside any regulatory framework for protecting personal private healthcare information, and it can also be used for marketing and sold for all sorts of commercial purposes. AHIP's core principles on protecting consumer health information are a roadmap to give consumers the peace of mind they deserve in knowing that their data is secure. And finally, we must absolutely maintain our focus on addressing health disparities and health equity. And AHIP has tackled this issue head on. I already mentioned earlier our Vaccine Community Connectors program. But last year, our Health Equity Work Group finalized and vetted demographic data standards for race, ethnicity, language, disability status, sexual orientation, gender identity, veteran status, and spiritual beliefs to facilitate the collection of information by health insurance providers and others so that we have the data that we need to better identify and act on healthcare disparities. And we're going to continue to build on this work to ensure that working together with public sector partners, the private market, and community partners, no one gets left behind. Let's turn to a really critical issue on the horizon with Medicaid redeterminations. And since the COVID-19 crisis, the number of Americans who rely on Medicaid has grown substantially. Today, almost 90 million Americans have access to healthcare and coverage through Medicaid. And this coverage was protected during COVID-19 by requiring states to pause annual eligibility determinations in exchange for additional federal matching funds to help cover the cost of that coverage. With the passage of the recent omnibus bill a few weeks ago, we now know that Medicaid redeterminations can begin on April 1st, regardless of when the COVID-19 public health emergency ends. In fact, the Urban Institute recently estimated that if the PHE expires in April 2023, 18 million Americans will lose Medicaid coverage in the following 14 months. What's more, tens of millions of Americans who currently receive Medicaid coverage still don't know this coverage could be terminated when states resume their regular Medicaid renewal process. That's why it's critically important that redeterminations be conducted in a manner that ensures people who continue to meet the eligibility requirements and are not disenrolled due to administrative barriers, and those who are no longer meeting requirements are transitioned to other coverage. And to protect Americans from losing access to health insurance coverage, states must actively communicate with Medicaid enrollees and, where necessary, facilitate a smooth transition from Medicaid to other types of coverage, including marketplace and employer-sponsored coverage. With 4 out of 5 Medicaid enrollees served by Medicaid managed care programs, health insurance providers are committed to playing an important and positive role to maintain coverage. Simply, we're committed to protecting healthcare access and coverage for almost 90 million Americans who depend on strong and effective Medicaid coverage and the Medicaid program. So let me close with a couple final remarks that healthcare is about serving people, and that's what health insurance providers do. And we're committed to ensuring that Americans can live their fullest, most productive life with access to affordable healthcare that ensures their financial health and well-being. And as we start 2023, there's opportunities to make a difference by addressing many of the issues that I touched on and more. And at this point, I'd like to bring in some of my AHIP colleagues who are experts in their field and can speak to how health insurance providers are focusing on improving care, cost, and coverage for all Americans in 2023 and beyond. Let me introduce them to you. Jeanette Thornton, Executive Vice President of Policy and Strategy. Jeanette oversees AHIP policy development for all health insurance provider lines of business, clinical innovations, and research. Mark Hamelberg is Senior Vice President of Federal Programs. He leads our work on policies that impact Medicare Advantage, Medicaid, and duals. And Miranda Motter is Senior Vice President of State Affairs and Policy. She leads AHIP's state enterprise, which covers all 50 states, as well as AHIP's political engagement with state officials, regulatory agencies, and key policymakers. And I'm so glad that they can join us here today for this dialogue. So submit your questions. We'll take some, but maybe I'll just start with one. And Jeanette, I'll turn one to you. And we know that President Biden just announced the most successful individual market open enrollment period to date. Maybe you could share your perspectives and thoughts on what's driving individual market enrollment and the increase that we're seeing, and is this sustainable?
Thanks, Matt, and so happy to be here. You stole my thunder a little bit with mentioning that HHS announced just earlier today that over or nearly 16 million Americans have selected a marketplace plan during this open enrollment as of January 7th. That's a 13% increase with really exciting number, 3 million new enrollees coming to marketplace coverage for the first time. Now, it's something to be said about the importance of the action that Congress took earlier this year with the passage of the American Rescue Plan Act, which provides additional help for people to afford their coverage through 2025. But I think your question is really key about what makes this market sustainable. We've seen more zero-cost plans, more competition in the marketplace, with individuals being able to have access to 6 or 7 choices in coverage. And I think we'll be looking in 2023 to see a continued stable regulatory environment so this market continue to be available for the millions of Americans who really are depending on it for their health coverage.
Thanks. No, we know how important it was to get the subsidies extended, the enhanced subsidies. I think that's going to be critical going forward as we think about enrollment in this market, and especially with the transition that we're going to see. Miranda, maybe let's turn to the state environment. We know states are off to the races with their sessions, and there's so many issues in play in the states this year. Maybe you could just share your perspectives on the role that health insurance providers are playing at a state level right now, just given all of the activity that we're seeing.
Absolutely. Thank you, Matt. Thanks for the opportunity to be here this afternoon. States are, in fact, off to the races. In January, 45 states plus DC will be convening legislative sessions for the year. And in those legislatures, according to the National Conference of State Legislatures, will be comprised of about 1,500 new legislators. We believe that states will be ground zero for major policy debates in 2023. And many of the debates will be squarely focused on access to and affordability of healthcare. I'll mention just a couple of issues in areas of centers of debate in the states. Matt, you touched on many of them, and then how health insurance providers are engaging and working in the states relative to these issues. First, we are likely to see legislative efforts in the states to eliminate important tools like prior authorization, which ensure that the care that patients receive is safe, effective, and affordable. We know that doctors and clinicians provide important care and life-saving treatment, and they all agree that we need to work together to avoid care that is inappropriate, unnecessary, and more costly. And yet we're seeing pressure in the states to limit the use of prior authorization and other important utilization management tools that we know employers and other purchasers of healthcare use today to ensure that the care that patients receive is safe, effective, and affordable. Health insurance providers are sharing with state legislators and policymakers the work that they're doing to innovate innovative solutions to streamline the prior authorization process and improve quality of care, reduce costs, and enhance patients' overall care experience. And so we're sharing that work and the extensive steps that health insurers have taken to improve this process. The second area of focus is that we are likely to see state policy proposals aimed at ensuring that Americans have access to mental health support and counseling. And Matt, you also talked about the work that the AHIP board did and the recommitment to major areas of work that need to be done. And certainly health insurance providers are doing that on the ground in the states. The last area I'll mention is certainly the cost of prescription drugs. Again, you mentioned that, Matt. Third, as I said, we're likely to continue to see policy proposals that focus on the affordability of drugs. And so, you know, as you indicated, purchasers of healthcare, whether that's employers, states, are very concerned about drug prices. And with pharma alone setting those prices, unfortunately, rather than lowering those prices, they are really seeking at the state level to advance pharmacy counter solutions, which would actually further disguise and potentially encourage price increases.
Yeah, the state environment is so dynamic and so busy, especially at the start of the year. As we know, sessions are back. It's definitely a lot to watch, and it's important to understand, I think, you know, what trends we see moving across the states, because those issues go from the states to the federal government, and we know have a really significant impact. Why don't we maybe turn for a moment to Medicare? So Mark, on Medicare Advantage, we're on the precipice of 30 million enrollees in MA. What do you think the keys are to keeping MA strong, given what we've seen by way of enrollment and how many millions of seniors rely on the program?
Thanks for the question, Matt, and I really appreciate being here. So you did note that tremendous level of enrollment, which has more than doubled in the past 10 years. And MA continues to have tremendously high satisfaction rates. So to keep the program strong, we submitted numerous recommendations to CMS in late August in response to their request for information on Medicare, which was primarily focused on the MA program. While I can't run through all of them, I can highlight a few. One of the most important ones is to ensure that the MA payment structure allows plans to continue to provide low-cost, high-quality coverage and the supplemental benefits that seniors increasingly value. So that includes improving how costs are determined in calculating MA benchmarks, making targeted improvements in the risk adjustment program, and also targeted improvements in the star ratings quality program. All of this is so important because MA plans, I think as you alluded to in your opening remarks, they provide more financial peace of mind than the original Medicare program. They offer lower cost sharing for many services, and they cap annual out-of-pocket costs, which the original Medicare program does not do. In addition to that, there are a lot of different ideas that we've put forward, considering ways to improve the availability and the benefits of MA plans in rural areas, providing additional benefit flexibility. As you had alluded to earlier, improving data collection to facilitate the advancement of health equity. That's something that cuts across all programs, but should certainly be something that we can work on in Medicare, both in MA and in original Medicare. And improving the search and the comparison functionalities of the Medicare Plan Finder tool. It's really important that Medicare enrollees have the ability to effectively review their coverage options. So that's just a small slice of the various recommendations we put forward.
Right. Go to the AHIP website if you want to read the whole long list of them. Absolutely. You know, one question that came in, it's a little broader than Medicare Advantage, but I think it's worth noting it's really more about payment reform. And we know that fee-for-service is a major problem impacting the cost of care. I guess maybe we can share a little insight on what we think about the role of payment reform is, and maybe what we're seeing out there in the market, and how important it is to really improve affordability, accessibility, and transform the incentives in our system. And I don't know, maybe Jeanette, you can sort of start with that, and then Mark, you can fill in with some MA pieces, because we know MA is sort of leading the way.
Absolutely. I think you can't talk about improving affordability without talking about payment reform and value-based care. It's just such a critical piece of that. I think we all recognize as a nation that we need to move away from fee-for-service-based care, right? It adds administrative costs, overutilization, has a tendency not to focus on outcomes, but the delivery of individual services. So I think we all agree that moving to a system where we have more proactive care, more teams-based care, and data-driven care is where we want to go as a nation. I will say that our health plans are really leading the way in this area. I think we have a lot of activities planned for 2023. Really will continue to drive the conversation around how to get away from fee-for-service medicine, because we do think it's a long-term goal of our healthcare system, and it's very important for us to get this done.
Yeah, and I'll just add that, as you mentioned, Matt, every year there's an analysis of how various programs utilize value-based care, and MA has consistently for years really been leading the way in the use of value-based care, and a lot of it is showing. I think in a lot of different ways, the data demonstrate how efficient and effective the MA program has been. Just a couple of examples. Through the bid process, MedPAC consistently shows that for the same benefits, MA programs are able to deliver them much more cost effectively. There's a lot of data that shows that Part A utilization is much lower in MA than it is in the original Medicare program. And when you do sort of an apples to apples comparison between costs in MA and costs in the original Medicare, including making sure that you're comparing the same enrollees in both programs, MA continues to be very cost effective. So I think, as you said, it's leading the way and is definitely something that we need to continue to focus on going forward.
Yeah, I think just one last sort of thought about it is we really learned with the pandemic how important it was for those systems that were aligned with value-based care and value-based payments, how they fared much better and differently than those that were relying on fee-for-service when hospitals were being, shut down for elective procedures and physicians weren't able to see patients in their office. And before the sort of rapid shift to virtual visits, right? Those systems and providers that were in value-based arrangements, we know did much better than those that were relying on fee-for-service. So I think just another area. Why don't we maybe shift for a moment? Question here about the employer market. We talked about Medicare Advantage. I teed up some things around, Medicaid, but the employer market's still, sort of the backbone of our system, covering 180 million Americans. It's so important still. Can you maybe talk a little bit about, sort of the role it plays, why it's so important, and how we can think about ways to make it more affordable? And then I see a question just came in that I can maybe add on afterwards, but I'll let you start there.
Absolutely, thanks. I think you hit it right on. It's the employer-provided coverage is really a bedrock of how people get coverage in this country. It really supports our world-class hospitals and doctors across the country. And it really is a mechanism by the American business community to really invest in their workers' health. It's become so important. Employer-provided coverage covers half of all kids across the country. And I think we all know a young adult that has benefited from being able to stay on their parents' plan while they're just getting started in their career. Matt, you spoke earlier about mental health. And I think we've seen during the COVID-19 pandemic how important employer-provided coverage was to make sure that people have access to mental health services and treatment. 1 in 4 people enrolled in employer-provided coverage in 2020 accessed mental health services and support, which is just really demonstrates how important it was to have that system available for people really when they needed it. And so looking at affordability, we recognize that employer-provided coverage needs to be affordable for American businesses and workers who rely on it. We've really been thinking about what immediate steps either Congress or the administration can take to really take some steps to look at these issues. We've really been pushing for changes in how chronic disease is paid for as part of high deductible health plans. Matt, you mentioned our competition agenda, really looking at legislative proposals that can tamp down on anti-competitive behavior, whether it's in contract designs or incite neutral payments in terms of how providers are getting paid. And also really making sure that new laws that are enacted, like the No Surprises Act, don't increase costs for workers and their families. So I do think there is a lot of areas that we have common ground that we can make improvements to make sure that the employer market continues to be there for the people that depend on it.
Yeah, it is, right? I mean, so many people still rely on it. We need to make sure that it's supported in the right way, given its role. Why don't we turn to an issue that I know we all think a lot about, prescription drugs, and the price of prescription drugs. And we have some new therapies that are coming onto the market. I shared a few statistics about how expensive they are, and median price for a new drug now well over $200,000. Maybe Miranda, I'll start with you, because there's so much activity happening at a state level with respect to prescription drugs. We know what happened, and we can turn to it in a moment with the Inflation Reduction Act getting passed. But maybe you could just share some perspectives on what you're seeing at a state level with respect to prescription drug efforts.
Mm-hmm. Absolutely. So I had mentioned earlier that the cost of prescription drugs is certainly an area that we are seeing a tremendous amount of legislative and regulatory proposals at the state level. With respect to drug proposals, I think, Matt, we're paying very close attention to two particular areas. First, we are seeing significant efforts by Big Pharma to continue to advance proposals that would protect the copay coupons. You talked about that earlier. These are really bait and switch coupons, and there are really aggressive efforts on the ground in the states to protect these. Copay coupons raise premiums for everyone, and they're just one more way that we're finding that Big Pharma is unfortunately price gouging patients and employers with out of control prices. Health insurance providers today are recognizing this bait and switch game and really want to hold drug manufacturers accountable. And so instead of assisting patients in a real way, in terms of, Big Pharma lowering the cost of their prescription drugs, they're not doing that. We're not seeing them doing that. But instead, they are really trying to advance proposals that would allow them to, in a deeper way, use these coupons. And it's really important to note that these coupons are illegal kickbacks in public programs like Medicaid and Medicare, which is really the reason why Big Pharma is focused on other markets and really encouraging patients to use coupons to drive them to higher cost brand name drugs. Health insurance providers continue to be committed to helping Americans, really protecting them from these schemes, which manipulate the market. Jeanette talked about the market manipulation that happens, and this is a place in the drug market where Big Pharma continues to really want to manipulate that. Health insurance providers, and we are really working on the ground to educate about these efforts and really encourage the underlying cost to be reduced. The second area that I'll just mention really quick that we're laser focused on, again, and Matt, you mentioned it, is efforts that we're seeing to restrict patients' access to lower cost drugs through the use of specialty pharmacies. Health insurance providers are constantly fighting for patients by developing innovative solutions that actually make prescription drugs more affordable. And one of these solutions is leveraging the use of specialty pharmacies to safely distribute physician-administered drugs in particular. These are solutions that help Americans and their out-of-pocket costs and what they are going to ultimately pay in premiums. A recent AHIP study actually emphasized this point and analyzed the cost of 10 specific drugs that were purchased through specialty pharmacies versus those that were administered in hospitals and in physicians' offices. And here's what the study found. The study actually found that the cost per single treatment for drugs administered in hospitals were an average of $7,000 more than those that were purchased through specialty pharmacies. In doctors' offices, so those drugs that were administered in physicians' offices, those were an average of $1,400 higher. So the data is really telling us how specialty pharmacies are lowering patient costs and preventing hospitals and physicians from charging exorbitant fees to basically buy and store these specialty medicines themselves and put them on their shelves. So we're encouraging policymakers to support competition among providers along the lines that Jeanette talked about earlier for these medications and services through the use of specialty pharmacies, and quite frankly, to reject the policies that would actually take away this lower cost option for patients.
Yeah, and Jeanette, well, I mean, those numbers are astounding. They really are when you think about, I mean, those are some real dollars that we're talking about there. And, as we, and Jeanette, this one's for you, as we think about, very expensive drugs, coming to market, one of the cost is one of the reasons that underlie the need for really important clinical tools like prior authorization, right? If you think about, less expensive, therapeutic alternatives, generics, biosimilars, going up against the marketing, DTC advertising efforts. We also need to think about it from a patient safety perspective. Maybe you could talk a little bit about the importance of these types of clinical tools to ensure that patients are receiving safe and valuable, high value drugs.
Absolutely. It really is our role as stewards of premium dollars to make sure people are receiving safe, effective, and affordable care, whether that's prescription drugs like we're talking about now, or other services that people may receive when they're accessing healthcare. And so this is why it is so important that there is some checks and balances in the system. We recognize that prior authorization and other medical management tools can be a process that the providers have to complete. We recognize that burden. And that's why our industry has really invested in electronic tools and methods to get this process done, minimize back and forth, ensure that there are faster decisions. And we really are encouraged by some recent regulatory developments that set standards and automated processes for these important medical management tools. Because I think, Matt, you said it. We want safe and effective and affordable care. And without these sorts of tools, we can't guarantee that that's taking place.
Yeah, absolutely. So, Mark, the Inflation Reduction Act, some pretty big changes on the horizon, especially for Part D. And we know 50 million Part D enrollees. I think it's pretty safe to say the biggest changes to the Medicare Part D program, since it was enacted back in 2003 and, up and running in 2006. Can you talk about some of the changes and the policy implications and what it's going to mean for seniors and Part D enrollees?
Certainly. And indeed, this is the biggest set of changes we've seen since the program began. So from a beneficiary perspective, a couple of important items, maybe among the most important, is that over a several-year period, they are phasing in a maximum out-of-pocket cap so that once spending reaches that limit, there will be no additional cost sharing, and it'll end up by 2025 being $2,000 as the cap. In addition to an annual cap, there also is going to be a monthly cap that would allow beneficiaries to smooth additional costs over the rest of the plan year. The overall structure of the benefit is being modified so that there are going to be different levels of subsidy for cost sharing of individual claims among the federal government, health plans, and manufacturers. So combined with the provisions that I just mentioned and some other design changes is effectively shifting more costs into the premium. In recognition of those premium pressures, there are provisions in the law that are designed to stabilize premiums so that they can't go up more than a certain percentage. I think people are probably well aware. I got a lot of publicity that starting this year, there is a cost-sharing cap for insulin. There's also a requirement for recommended adult vaccines to be covered without any cost sharing. There's an expansion of the Part D low-income subsidy program. And among the sort of broader provisions that affect both Part D and I'll mention this in a second, potentially other areas are drug price negotiation. So since the start of the program, there's been a non-interference clause that prohibited the government from being involved in negotiating prices for Part D drugs. That's been lifted for certain drugs meeting certain criteria. And also a rebate to be paid to the government if drug prices increase for brands faster than the annual rate of inflation. So what are the implications of all these changes? Obviously, the maximum out-of-pocket provisions, that the absence of that has been one of the major differences between the Medicare program and those with drug coverage in other programs. So that clearly is an important change. But there are, as I mentioned, the potential for significant premium pressures, which could end up translating not only to some increases in beneficiary premiums, but significantly higher government costs, as well as the government subsidizes a significant portion of those premiums. We're going to have a lot of operational challenges in the healthcare world to implement these various changes, and there's significant uncertainty about the impact of both the inflation rebate and the negotiation provisions on things like launch prices in the program, on whether it could affect decisions that manufacturers make in what drugs to develop and how and when to price them, and whether manufacturers might attempt to offset reduced costs in Part D by looking to raise costs either elsewhere or including in commercial coverage. So I think there are a lot of unknowns. But certainly, given how big the program is, as you mentioned, over 50 million people, and the costs for many drugs in the Part D program, the implications of all these changes could be quite significant.
Yeah, and I think CMS just came out with some new information on timelines today that we'll have to be looking at. Interesting questions just came in, and I think, Jeanette, I'll direct this one to you. Thinking about affordability and competition, and it's around the incentives that we're seeing or actions with respect to private equity. And if you could maybe just touch on, I know I've said before, there's good private equity that's looking to make healthcare more accessible, more convenient, more affordable, really improve the system, and there's others that seem to be trying to take advantage of loopholes. Maybe you could share, some examples here, and also maybe share the latest on what we're seeing on surprise medical bills, because we know that was there's a big relationship there.
Absolutely. I think one of the reasons Congress decided to pass the No Surprises Act into law, which, as many of you likely know, really protects consumers from in an emergency getting a balanced bill if they happen to take an air ambulance ride or go to an out-of-network emergency room, is that we've really seen a surge of private equity investment in what we call fee-for-service medicine, emergency rooms, anesthesiologist practice, other practices where people don't have a choice. Who wakes up in the morning and says, hey, I want to go to this anesthesiologist? Nobody does that. And so it's really been quite concerning, and I think it really has an impact on affordability. So one of the things that we've been really calling for is more transparency. We think it's important for patients and consumers to know when a private equity firm is investing in certain fee-for-service specialties. We think this will go a long way to opening up this conversation with the American public about what's happening in medicine. But specifically regarding the No Surprises Act, it's really been interesting. Right before the Christmas holidays, CMS put out its first really comprehensive set of data in what's been going on with surprise billing, who's been using the new independent dispute resolution process to seek payment as for out-of-network claims that are covered under the law. And it's really been quite surprising in one way and not in another, in that we've seen a lot of private equity-owned firms and staffing firms really utilize arbitration to a high degree to seek payment. And we know it's a new system, we know it's a new law, and there's a lot of rolling up our sleeves and getting used to these new processes and procedures. But we really are concerned that certain providers will be using this process to seek higher payment, and that's directly going to impact the costs that employers pay from premiums and that individuals pay for premiums. So we've really been working closely with the administration to seek some improvements to the process and really support the administration in over a dozen case litigation activities that are out across the country to really make sure this law remains strong and that people can depend on it moving forward.
Yeah, quite a number of lawsuits out there.
Might have gotten that exact number wrong, but close.
A lot. Let's put it that way. So we have about a little less than 5 minutes left. If you have a question, please submit it. One came in around redeterminations, and maybe this is probably joint Jeanette and Miranda. Can you share a little bit more information about how states are thinking about redeterminations and what role health insurance providers are thinking about playing, given the challenges that I outlined in the beginning?
Want me to kick it off?
Sure.
Kick it off? Absolutely. So, as you indicated, Matt, with the passage of the omnibus language at the end of the year, states now have a date certain of which the redetermination process will begin again. States have been planning. They have been working towards this before the continuous coverage requirements were decoupled from the public health emergency. They were working towards this. Now they have a date certain that they're going to have to work through redetermining large numbers of Americans. You mentioned the numbers earlier. I think states are thinking about that volume. They're thinking about making sure that their employees within Medicaid agencies and at the county levels are ready for this. States are trying to do education and campaigns and outreach to those individuals that are on the Medicaid program so that they can anticipate the work that needs to be done and the paperwork that's going to need to be submitted to make sure that individuals can maintain that coverage as long as they continue to be eligible for Medicaid. As I said, the volume's going to be significant. It's going to impact even those individuals outside of those that are receiving coverage. So, for providers that had a source of coverage for individuals that may lose that coverage, it's going to be really important that there is work across agencies. So not just within Medicaid agencies, but with insurance commissioners, with the exchange marketplaces, within the governor's offices. And it's really important that states work very closely with their Medicaid managed care plans, where they have those partners in the states on the ground. Medicaid managed care partners can be very helpful in terms of making sure that states have most up-to-date contact information, that they can help to do that outreach. And then it can also really help in terms of making sure if there does need to be a transfer of coverage either into the marketplace, that they can assist with that too. So the qualified payment or the qualified health plans that are part of the marketplaces, to making sure that the individuals have coverage and have a place to seek that coverage. It's also going to be really important for the employer community to understand what's going to happen now as well, because some of the individuals will have access and be eligible for the employer coverage that they now may be eligible for. And so a lot of focus, a lot of attention, a lot of work that is being done, and plans stand ready to be very active partners with policymakers and other stakeholders on the ground.
Right. It's our goal to make sure that people stay covered, whether it's still on Medicaid or another form of coverage, and really, really committed to working with states to make that happen this year.
Yeah. On that note, you couldn't have said it better, Jeanette. I mean, we want to make sure that everyone who has coverage today stays covered and really minimizing any disruptions or drops in coverage. Well, I think that brings us about to time. And thank you, everyone, for joining today's event. We really look forward to continuing this robust discussion throughout the year and beyond. And also, I'll just hope and make a note that you might be able to join us at our 2023 Healthcare Policy Forum in Washington, D.C., March 14th through March 16th. And mark your calendars for June, AHIP 2023, June 13th through the 15th in Portland, Oregon. Hope to see you out there too. So thanks again for joining. Take care. Hope you have a great year, and we'll be back in touch soon. Thanks, everyone.